Hi, everyone. Welcome to today's Talking Point presentation. I'd like to begin by acknowledging the traditional owners of the land on which we meet today. I'm currently on Wurundjeri Woiwurrung land belonging to the people of the Kulin Nation, and pay my respects to their elders past, present and future, and extend that respect to Aboriginal and Torres Strait Islander people listening today. My name is Associate Professor Victoria Manning. I'm the Head of Research and Workforce Development here at Turning Point, and I'll be facilitating today's Talking Point, which is lived experience and academic partnerships, a case study of meaningful collaboration demonstrated through the AOD Patient Journey Project. And this is presented by Amelia Berg and Dr. Leanne Francia. I'm sure many of you have come to Talking Points before, but really the aim is to inspire, inform, and challenge our notions of what we know about addiction and its impact across our society. We like our webinars to be as interactive as possible, so please ask questions via the Q&A function. The questions will be collated and answered by the presenters at the end of the presentation. And our webinars are recorded and are available to view on the Turning Point website. So I'm going to introduce today's speakers. The first is Amelia Berg. Amelia currently works at Shark as a lived experience peer worker. Amelia has worked in harm reduction for over 10 years and has experience working with people who use drugs in an outreach capacity and in research. Amelia is currently working on Fuse initiatives in partnership with Harm Reduction Victoria to expand and support the living experience peer workforce in Victoria. Our second speaker is Dr. Leanne Francia. She's a researcher here at Turning Point and at the Monash Addiction Research Centre. Leanne's qualitative research centres on the lived experiences of those endeavouring to seek help from and engage with healthcare services, the systems and the organisations with which they intersect, and programme evaluation. Leanne has a broader background in researching vulnerable and sensitive populations, including people who use violence, victim survivors of family violence, and sexual offenders in the criminal justice system. So over to you.
Thank you, and welcome everyone today. So these days in alcohol and other drug research, there's a lot of talk about co-design and collaboration with lived experience as consumers. And our talking point today will present a case study on a recently completed project in the Frankston-Mornington Peninsula region in Victoria that demonstrates both the challenges and the benefits of collaborative partnerships between lived experience and academic researchers. So Amelia and I will go behind the scenes today to identify what worked in the collaboration and to provide an overview of the development of the tangible findings from the research into knowledge translation. But firstly, we would just like to put a disclaimer at the beginning for you all that some of our content does contain swear words and at times descriptions of experiences that the participants have shared. So there will be details of appropriate services at the end, should these cause any concern or distress for any of you. However, if you do at any point feel uncomfortable, please feel free to turn down your sound, have a break from the webinar, or if needed, to actually leave the webinar. For all the quotes and experiences also that we share today, these have been amended to take out any identifying information and as much as was necessary to ensure participant confidentiality.
We'd also like to acknowledge the people with lived and living experience of substance use and the experiences of those who support them. We recognise the vital contribution of lived and living experience at all levels and that the voices of people with lived and living experience inform all of our work. I'd like to just start by explaining what lived experience or living experience is and what a lived or living experience peer researcher is. Lived or living experience refers to a person who has experienced a particular issue such as alcohol or other drug use, or who has been impacted by someone else's experience with a particular issue. So the experience can be in the past, such as someone who identifies as being in recovery, or it could be current, as in someone who is currently engaged in alcohol or other drug use. It can be direct, as in a person who has personally experienced the issue, or it could be indirect, such as a family member or significant other who has been affected by someone else's AOD use. A lived or living experience peer researcher is someone who is involved in designing and conducting research about a particular issue who also has a declared experience of that issue. We are recognised as sharing similar experiences to the community that is involved in the research. For example, I have a history of injecting heroin use and have experienced accessing AOD, mental health and other health services in the Frankston-Mornington Peninsula area. I was engaged as part of the research team through all stages of the research process, including the development of the qualitative interview schedules, conducting the research interviews with participants, data analysis and report writing. When doing research with people who use alcohol and other drugs, it's so important to involve us at all stages of the research process. AVIL, the Australian Injecting and Illicit Drug Users League, which is the national peak body for people who use drugs, released this national statement on ethical issues for research involving people who use illicit drugs and who inject in 2003. This statement addresses numerous ethical issues such as employing peer researchers, making sure that the research is peer-driven at all stages of the research process, storage and security of sensitive data, especially as it relates to information about engaging in illegal behaviours, and payment of research participants. I would encourage all researchers to familiarise themselves with this national statement and to adopt the ethical considerations contained within. This will ensure a consistent approach is used across the research space, as well as providing guidance on best practice for ethical research with people who use alcohol and other drugs. So co-design is a word that we hear get thrown around a lot. And to be honest, I think that often we're not actually all talking about the same definition. So for sometimes when people are talking about co-design approaches, it sounds more like they're talking about consultation with consumers. So we want to be really clear about what we mean when we use the word co-design. This infographic beautifully captures our working definition. It's about educators, researchers, clinicians, all partnering with consumers right from the get-go to define the problem and then designing and delivering the responding interventions together. And most importantly, it's about having shared decision-making power at each stage of the project. When choosing things that you'd like to research, you should consult with the affected community first to see what the community's needs and priorities are. As a team, we actually prefer the term collaboration as opposed to co-design because it signifies a meaningful collaborative partnership. So why involve peer researchers? Well, lived and living experience peer researchers have close connections to the community, so we know what the current trends, needs and priorities of the community are. Participants often report feeling more comfortable to disclose sensitive information when a peer is present, simply because they know that we get it and we won't judge them. This can help mitigate traditional power imbalances between researchers and participants, as we can act as a bridge of understanding between the academic researcher and the participant. People with lived and living experience see and hear things differently. This can often come across in things like what language is appropriate, and we can also identify things that academic researchers may not actually think of. We'll learn new skills and we can also teach you stuff too. Our shared experiences with community often leads to participants disclosing way more to us, meaning that the data that's collected is much richer. However, there can be some challenges. Peer researchers may need additional training or support from the research team, particularly if we haven't been involved in doing research before. If you use a dual interviewing technique like we did, where both the lived experience peer researcher and an academic researcher conduct the interviews together, then there can be different power imbalance created by having a 2-on-1 approach. Also, if not done right, there can be a power imbalance between the academic researcher and the peer researcher. So both of these relationships really do need to be managed. As part of the Royal Commission into Mental Health Services in Victoria, there were several recommendations regarding lived and living experience and how services can integrate lived and living experience peer workers in order to improve service delivery and outcomes for clients. Following this, the Department of Health have initiated a massive program of work which recognises the value of lived and living experience and aims to expand the peer workforces across the AOD and mental health systems. We hope that the meaningful involvement of people with lived and living experience is further expanded into the research space. One thing worth mentioning is that people with lived and living experience can be employed under numerous job titles. We can be called peer workers, lived or living experience peer workers, service navigators, or peer support workers, just to name a few. The similarity between these different job titles or descriptions can be boiled down to the fact that the individual is employed expressly because of their past or present experiences and that they contribute a valued and unique type of service to clients. There may be some differences apparent in the setting in which they're working. So they might be working in a clinical environment such as a hospital, or they could be working in an outreach model or in a community health model. They could be employed by a peer-led organisation or in a research environment. They will demonstrate, there's different ways in which they can work as well. So, if a lived experience peer worker may be operating under a recovery framework where they're providing support to people in treatment. So they'll be demonstrating and empowering clients through a lens of hope and recovery. A living experience peer worker may be employed within a harm reduction lens, providing support and education to clients on how to use AOD in a safer manner, whilst assisting them to navigate services without the expectation that they cease using.
So moving on now to the actual research project. The original proposal was developed in partnership with SHARC, the Self-Help Addiction Resource Centre, and local health services and an academic institution. And representatives from all these organisations also served as investigators on the project. So the research project aimed to improve care by engaging with people who had experienced problematic alcohol and other drug use, and better understanding their experiences both of help seeking and accessing treatment. And the project specifically wanted to identify the barriers and facilitators for both consumers and healthcare services in order to improve access to care. So initially there was a lot of back-end work done through stakeholder workshops, which were attended by both consumers and healthcare service providers, in order to identify what the priority populations were in the local region. And the three identified populations were women, people who were experiencing homelessness, and older adults. So interviews were then conducted on these populations. And Amelia contributed, as she said, to all stages of the project. However, Amelia only participated in 22 of the 39 interviews. And I'd just like to park that statistic there with you for discussion on a later slide. So due to the ongoing lockdowns in Victoria, Amelia and I basically only met over the course of a year, only online. So when we were first introduced with each other, we identified as belonging to separate communities. So Amelia identified as belonging to a lived experience community, and I identified as belonging to an academic community, which arguably created an insider-outsider dichotomy. However, rather than this actually being a limitation, we found that this binary served as a great starting point from which the dimensions of our similarities and differences as they related to our roles and our areas of expertise were able to be reflected on and discussed. So if you like, it became a bridge that we traversed back and forth across together. So in the beginning, there was a lot of knowledge sharing between us. I learned insights into various drugs, the language used by people who use drugs, such as the street names of various drugs, and the often ritualistic nature of preparing and administering drugs. And although Amelia had previously collaborated on other research projects, these projects had only involved data collection through surveys. So now Amelia was introduced to a qualitative approach, which gave her the opportunity to learn new skills in interviewing and in qualitative data analysis. And together we discussed who would take the lead in the interviews, and we decided to alternate this together. And this approach enabled us to have ongoing discussions on what was working, what we could do better, and what supported participant engagement. Amelia was able to observe the interview style of myself and where she felt appropriate to incorporate that into her skill set. And I was able to observe how communication between individuals who have that mutual lived experience of alcohol and other drug use, incarceration and stigma could stimulate increased participant disclosure. And I'd just like to share one example with you now. So one participant that we interviewed who had not initially referred to opioid use made a passing comment regarding Suboxone, which Amelia immediately picked up on, commenting, "So I'm guessing opioids are a concern to you." From there, we were able to identify which opioids were used and then delve deeper into the participants' concerns as they related to these substances. And this enabled us to contextualise the opioids amongst the other substances that they were using. And this earlier information was important because as the interview continued, the participants shared their experiences of treatment as it related to prescription medication and a recent surgery that they had undertaken. So having Amelia in the interview enabled us in real time to capture richer data. So through our dual interview approach, we were able to explore emerging themes, use appropriate language, and take care where participants had experiences of stigma and trauma. And for a number of our participants at the time of interview, their lives were complicated by a number of challenges. And although the participants had given informed consent and were willing to participate, in real time, having Amelia in the interviews created a safe space where we could ensure that the interviews were not a burden or causing any harm to participants. And this was so important given the sensitive and personal nature of what the participants shared with us. So Amelia will now share two brief examples, but before she does, I just want to reiterate that we have redacted and changed specific details of the participants' backgrounds and experiences in order to ensure their privacy and confidentiality.
Thanks, Leanne. So one participant at the time of interview had had a friend pass away a few days earlier, and also was at the same time as the interview was being conducted, was undergoing withdrawal whilst waiting access to rehab. They shared with us an experience of a presentation at a local hospital. Having a back injury, they had asked the nurse if they could get a bottle for them to urinate in. The nurse reportedly scoffed at this request and said that she had real patients to treat. When the nurse came back into the room, the participant said to her, "Look, I understand that you can have your own opinions and whatever, but I'm like, I've served in the military, I've got multiple degrees, I'm not a shit person, I've just had a really fucking hard life." In this discussion with the nurse, the participant was a lot more specific in recounting the details of their experiences and reported that they were trying to demonstrate to the nurse that there were so many more aspects to their experiences and their life outside of the context of their attendance at hospital for substance-related concerns. Expanding on this, the participant shared information with us on many graphic and traumatic events which had had profound effects on their life. They spoke fondly of their mother and sisters with whom they were still close today. They had not had a lot of money growing up, but had worked hard and earned all that they had now. The participant described a range of events that were clearly distressing and included things such as serious accidents and events where fatalities were personally witnessed by the participant, alongside experiences of family violence and childhood sexual abuse, which provided clear context for the ongoing psychological trauma that they were currently experiencing and which was entwined with their substance use. They shared how they had explained this to the nurse and how, in their own words, they said, "I was involved in a lot of fucking shit that I wasn't okay with. I just had shit happen to me and it doesn't define who I am. I'm a fucking nice person. I tried to explain that to the nurse, but people just don't care. They have opinions and most of them are wrong." Another participant that we interviewed had been on the street since they were 13 years of age, and they had begged to go to rehab instead of getting another stint in jail. They spoke to the incredible pain that they felt after the death of their partner at the time of incarceration. Once in jail, this participant described the ways in which they had attempted to end their life whilst incarcerated. I'm not going to go into the graphic detail, but the participant spoke to the great lengths that they had gone to make others see their desperation for help. The outcome was that they never actually got to access drug treatment whilst in jail. They spoke to the absence of any form of rehabilitation or treatment available to them, and to them, they said jail was a place where, in their words, criminals either get smarter or stupider.
Thank you, Amelia. So these are examples that speak to the challenges faced in accessing treatment with a known substance use disorder. And as I said, the actual details of their circumstances in their life that had led to their experiences of addiction were graphically shared with both of us in the interviews. However, within a dual interview approach, there was a safe and informed space in which participants could present the whole picture of themselves and the fullness of their experiences, together with the frustration that they felt at healthcare services' unwillingness to see this, and also the influence of stigma on healthcare service provision. So these are examples of people being much more than one behaviour that they may engage in. And there were many more examples that we were given. But yes, people may use drugs, but they are a whole person with various experiences, and they are entitled to access healthcare services that are not judgmental or discriminatory, irrespective of their substance use. So, as I said, there were more examples, but regardless, and in the middle of lockdown also, Amelia and I were able to engage 39 participants who remained willing to share their stories. And as we've briefly highlighted here, stories that were very intense, graphic in their descriptions, and of a personal and very sensitive nature. This was their lived experience, and this had all contributed to their life and problematic alcohol and other drug use. And in these contexts is where Amelia and I were, in our areas of expertise and research approach, we continued on a deeper level to reflect on our experiences of the interviews, the experience for our participants, and also at times our own lived experiences as well. And this here again highlights this bridge that we mentioned before, so that we were able to traverse back and forth numerous times throughout the research project together. And it was a space in which we were able to probe pertinent questions and ask those and have meanings clarified as well. And all of this enabled knowledge building, creation of a safe space, and skill progression. Another potentially challenging context in the project was where healthcare staff shared stigmatising observations or used stigmatising language in the interviews. So here again, it was important to ensure that Amelia was not traumatised because of these negative reflections of her own lived experience. And our next slide provides some examples and context. So these quotes, as well as being examples of language that some healthcare staff may use, give insight into the personal experiences of participants on the receiving end of stigmatising language in healthcare service provision. So one healthcare staff member, Asmi, in a hospital setting, described how there was a priority of getting people who use alcohol and other drugs out of the service as quickly as possible. We meet them, greet them, treat them, and street them. Others record hearing healthcare staff refer to those experiencing problematic alcohol and other drug uses. A freak or something, they're just a piece of shit, he's just a scumbag. Another staff member, Connor, reported hearing a colleague tell a patient, "You're doing this to yourself. You're not sick. That person with the heart attack, that's our sick patient. You are just wasting your time." And Chow told us, "I know we're all drug addicts and that, but don't speak to us like we're drug addicts. It's fucking rude. We get it. We get what we are, but we're trying to get help. And that's why we're here. So treat us like humans. Don't treat us like we're drug addicts. People aren't going to respond well to being treated like shit. Through these examples, you gain a sense of what stigma can look like, sound like, and feel like in the healthcare setting. I'd like to move on now and share with you some of the outputs from the project. So on the other side of the project, we have been able to publish a number of papers or have some under review. However, today I'll just be focusing on the two that directly relate to those with lived experience. The first article sets out findings as they related to peer workers and the unique contribution that they make in the hospital setting, which is strengthening of the therapeutic alliance through having trust and credibility, by having shared experiences that build hope, having the ability to be approached on a more informal basis, and being accessible long term. So although these findings do partly echo earlier literature, we did identify two innovative aspects that related to the peer worker role and expertise, being the ability for peer workers to be approached informally and the opportunity for longer term engagement. So, and this is something that often does not exist with clinical staff who may only have a set number of appointments available for a patient. The second paper on the screen was focused on healthcare staff stigma and their use of language. So we identified three themes where language use materialised as a means of stigma communication. So this was the use of language that firstly positioned a patient as undeserving, and we saw some examples on the previous slide where patients were referred to as a freak or a scumbag. Secondly, the use of language that separated a patient from other patients. And again, there was an example on the previous slide that referring to the person with the heart attack as their sick patient, not anyone else. And thirdly, language that blamed a patient. And one participant shared this when they commented, I just think to myself, oh my God, a lot of them, they just don't seem to learn. So this use of language had a negative influence on staff decision-making as it related to healthcare provision, and it also impacted the patient's future help seeking. So, and although there are a number of target interventions that address language and stigma towards people who use alcohol and other drugs, these findings suggest that change may be inhibited if staff themselves do not realise that their own use of language may contribute to the perpetuation of stigma. So next, I'd just like to share our rationale and approach in developing another output from the project, which is the visual presentations or posters. So in addition to collaborating with Amelia, it was also important to involve an illustrator in the project. So this was primarily because the team wanted to share the findings with a variety of audiences. And as we saw on the last slide, research is traditionally conveyed in the form of peer-reviewed journal articles. However, these might not be accessible to many, and there can be a number of reasons, including that the articles might be too long or difficult to digest. They may be targeted at a narrow audience, may contain complex statistics, or just the costs in accessing may be prohibitive for some. So we wanted to communicate our findings to a broad range of audiences that included healthcare staff and funders, and to create resources that organisations and funders could pick up and use in differing contexts and understand. So some of the posters we developed were to comprise part of a staff education program, which was to be rolled out in the local healthcare service, and others are aimed at funders and stakeholders. So to achieve this, we engaged with a graphic illustrator to help us create a number of visual resources. So these visual resources or posters summarise the written content in engaging summary and were designed to be understood intuitively, and ultimately made the findings accessible and interpretable to people who might not otherwise see the research. So to do this, the first step was for the team to write up a report, and it ended up being about 20 pages long of all that our interviewees had told us. So the report was provided to the illustrator as background reading, and following this, the research team, which comprised it for this part, Amelia, myself, and 3 other investigators, engaged in an iterative process with the illustrator where we regularly discussed the resources and threw around ideas of what the structure and content might look like. So the top half here of the slide shows how our visual ideas were developed over a number of months. And as you can see, the structure changed a fair bit as a result of all the back and forth between us, because the illustrator did not have expertise within the field of addiction. That meant that the research team had to be quite clear about why there were certain things that we did need to have included. And also we had to simplify some of our more convoluted ideas in order for those to be connected to a wider audience. So once we had a draft version of the resources, we then held further mapping workshops with our interviewees. And within these workshops, participants were able to share what messages they felt important to be included, what needed to be a higher priority, and how those messages might also specifically look. So in this way, we close the loop with consumers and healthcare service providers and stakeholders. And participants said that the resources were a much more accessible way of providing feedback of the outcomes for the project.
As part of our process of consumer involvement and collaboration, we shared the resources we had developed with the Alcohol and Other Drug Consumer Advisory Group at Peninsula Health. In turn, the Consumer Advisory Group decided that they also wanted an additional resource developed, and they were able to work with our graphical illustrator. So the graphic on your left is the resource that we had developed throughout our project, and then they developed the additional resource on the right of your screen, and they were able to work with our graphical illustrator to do that. At the same time as we were working on these resources, Peninsula Health staff, Jess, who is a lived experience peer educator, and Kirsty, who is an AED educator, were consulting with stakeholders in the hospital about alcohol and other drug learning needs. Here they found that the same theme was emerging and that there was an appetite for us to work on building understanding and compassion for people who use drugs amongst clinicians. So it was brilliant to have these resources produced by this research project, and that the Consumer Advisory Group was able to adapt them further. So Jess and Kirsty wanted to see these resources well utilised and, really built into education processes, because there's only so much impact that posters can have, and that they felt that they could have a much better reach and impact if they were used as part of a larger healthcare education and social marketing campaign. So Jess and Kirsty drew on marketing strategies to promote the adoption of destigmatising language and promote behaviour change, both at an organisational cultural level and at an individual clinician level. They worked closely with their corporate and communications teams to build a campaign that around the simple, unified key message of your language matters, which is on all of the posters. They then developed a suite of resources to enable message repetition through multiple channels. So they developed a virtual background that was used in Zoom meetings and a screensaver for staff desktops. They put an article out in the e-newsletter about the impact of language and stigma, and also provided talking points for managers to use in team meetings. Jess and Kirsty also produced a 4-minute video with support from the Frankston-Mornington Peninsula Primary Care Partnership about the impact of stigma and the importance of using language so that people don't feel judged because of their substance use. They were supported by managers at Peninsula Health, who also featured in the video. This managerial buy-in and participation was really important and effective, because using people who are respected by the target audience and known by the audience to disseminate campaign content increases the likelihood of behaviour change. They also knew from previous research that contact-based strategies have been key in how they delivered the research. So bringing healthcare workers into contact with people with lived experience helps challenge stereotypes about people who use alcohol and other drugs. So with the posters, rather than just sticking them up on the walls, Jess and Kirsty went around to all of the wards in the hospital together and did brief education sessions with staff. The interactive training sessions co-facilitated with Jess gives the opportunity for hospital staff to be exposed to someone with experience of substance use as an equal rather than as a patient. They also developed an online self-complete module that staff can do as well. And the other activity that they've been doing is revising Peninsula Health incident reporting tools and screening tools to update language so that they're all using the preferred language as well. Because having terminology like substance abuse in screening tools would undermine the language change that we're hoping to achieve. Jess and Kirsty were able to get fantastic reach with their campaign. Whilst the campaign has officially ended, they have continued to deliver the co-facilitated education sessions on the wards and have been distributing the posters across numerous Peninsula Health sites. They have also received positive feedback on the impact the campaign has had on service providers. On the screen here, we have 2 quotes from staff who have participated in the training sessions, and they really highlight how interacting with the lived experience educator and learning about the effects of language has had on their professional practice. So as Leanne mentioned previously, that whilst we covered the entire journey of a research project together, Leanne and I actually only met once in person throughout the entire project. We were in the middle of lockdown, so everything happened on Zoom. So how did we make it work? Well, we took time over Zoom to meet just the 2 of us external to the rest of our research partners. And we just shared our stories. You know, we spoke about our personal and professional experiences. We talked about all kinds of stuff, you know, our pets, what work we'd done previously. I told Leanne, you know, some of my story about drug use and, you know, accessing treatment. We had mutual respect for each other right from the start, and we were also keen to learn from each other's experiences. Earlier on, Leanne mentioned that I was only involved in 22 of the 39 individual interviews, so just wanted to speak to that for a little bit. Because this kind of highlights some of the barriers that can exist in collaborations. And that's the provision of funding and payment for the necessary investment of time across a research project. So in our project, I was employed for 4 hours a week across this entire project for a number of months. And although I really did try to be as flexible as possible, it just wasn't always possible. So I didn't have that flexibility that would normally be available to full-time academic staff to actually carry out all of the interviews at times which suited participants.
So today we've shared our approach and experiences which we believe reflect within meaningful collaborations the importance of relationships that maintain integrity in both lived experience and in research. And Amelia and I have clearly developed a great relationship together. And as time has gone on from the project also, we have had other opportunities to share our experiences such as this in this presentation today. Our team did a whole project under one of the longest lockdowns in history, and it's an example of what can be achieved when and how creative you can be when life changes as well. But relationships were at the crux of it all, and this work wouldn't have been possible if there weren't many people who were invested in engaging in, who put a lot of energy into investing into them. And this extended beyond the relationship that Amelia and I have developed. So prior to this research, there had been a lot of work done by the Monash Addiction Research Centre, who was heavily invested in building relationships with Peninsula Health and the Self-Help Addiction Resource Centre. So our take home is that meaningful collaboration requires strong mutual respect for each other's expertise and contribution, together with good communication between stakeholders, be they academics, clinicians, educators, or living or lived experience workers. And I'd just like to share at the end a photo of some of the team who we would also like to acknowledge in today's presentation as well, which is Professor Susie Nielsen, Dr. Tina Lamb, Kirsty Morgan, and although not pictured, Professor Dan Loveman. In addition, we would also like to thank the other investigators, Peninsula Health's Consumer Advisory Group, and all our research participants. And please also approach these services should this presentation have raised any issues for anyone today. Thank you.
Thank you so much, Leanne and Amelia. That's such an excellent presentation on such critically important work. I think it really is clear we've got some way to go before we eradicate and certainly reduce stigmatizing language and stigma in healthcare settings. But I'm really pleased to see that you developed some fantastic tools in the posters to go some way to achieving that and changing behaviour. And on the posters, we did have somebody ask in the Q&A where they can get hold of them, where they can be distributed.
I think the Monash Addiction Research Centre website has them up, but that is something that I would probably have to follow up as well, that I could provide that information. Yes, yeah.
Okay, fantastic, thank you. Okay, well, we have some questions around the potential for future collaborative research. Where do you think the greatest need is?
Ooh, I think that depends on the community that you're wanting to actually do the research with. So, I mean, there's so many ways that we can actually approach this. Like, you could come up with an idea as a researcher of what you're interested in and where you think a need is. And I mean, that's great. But, really what should happen is that you should be approaching, the relevant, is it a drug user or is it a treatment agency? Approach the community directly and ask them what they think needs research being done, because your ideas may be great and they might be what we need, but often it's not, it might be a valid thing that you're wanting to research, but we might be like, oh well, actually, yeah, that's great, but what about this? Because this is the thing that our community is actually really experiencing. And then let that conversation guide where you're going with your research. And then don't just involve, drug user orgs simply for the point of recruitment. Don't just get us to do the, bring in the peeps to, be your research participants. Actually include us at all stages in the process. And then that will mean that your research is that much more, meaningful and more easily translated. Because if it's not relevant, it's not actually going to get implemented and accepted by community.
Absolutely. And you've just answered Michael Savage's question there. We have a similar one. Which avenues would a community use to make contact with researchers?
Oh, that's harder in a way, I think, because I think, we would have a lot of ideas, and I think it's just about knowing, if you're a member of a particular community, knowing who sort of represents your interests and, the voice for your community, and then approaching them and saying, hey, I'm finding this is a thing. Is there any way we could do some research on it? And then the relevant organisation, the drug user org, would then reach out to research institutions and see, who might be interested.
Yeah,
it's a tricky one because there's so many research institutions.
There are, certainly I can speak for Turning Point, and we always welcome ideas and areas of importance in terms of future research efforts. So and also VADA as well can be there's information at VADA for contacting research groups and individual researchers. You mentioned, you talked through the various sort of roles and settings in which peer workers with lived and living experience work in. I was just wondering what peer workers looked like what they look like in the local hospital setting in the context of this particular project. Like, how many did you have? And
Yep. So in the local hospital, I think they've got 2 lived experience peer workers. One is for youth, and other just for adults. And I suppose one thing with them is just having a smaller number, but also the fact that the hours that they're there as well. So they're normally there during work hours as well. So not necessarily when there might be other patients coming through at different times when there might be. So that they are there, but there's just 2 of them, and in within those short business hours as well. Yeah.
Ben is saying that he has the posters in his offices, and the language means so much. So lots of great comments and positive comments in the Q&A. Can you tell us a bit more about how you handled some of those intense interviews, sort of around the debriefing processes? Because there was a lot in there.
Yeah, I think we set it up right from the start that after every interview, no matter how it went, that I would telephone Amelia, or we would stay on the Zoom after if it was online. So we had that, we would do that together. And I think it was just really about listening to each other afterwards, and again, just having that safe space for each of us to share our own observations or how it might have impacted each of us individually, and then just being able to debrief more around that, and just being aware too that whether or not we might need to check in with each other before our next one as well, sort of thing.
Yeah, that was super important, just because, some of the interviews were, super intense and quite distressing at sometimes, like, with the descriptions, when you're hearing, the experiences that people have had, it's, it's not easy to process that. And, it was just awesome having that arrangement with Leanne, and it was like really natural, that we just got together after the fact and had a chinwag about how did we actually feel in each of these things. Then we broke it all down, and I think if we didn't do that, things would have been very different.
Yeah, and I think it was also important for us to make sure that the participant was okay as well, so that we'd actually gone through that at the end, that debriefing with the participant before leaving the interview as well, and then discussing that as well, so that we could keep that at front of mind throughout the whole process. Yeah.
Jacqueline is asking. She works at a reception in a prison inpatient unit and would like to see language training there. Have there been some development, or are there any sort of future developments for this work and posters in other settings?
Oh, I hope so.
Yeah. I think so too.
To my knowledge, no prisons have reached out yet, but maybe Jacqueline could give them a nudge and point them in our direction, and we could get the posters up in the prison units, because I think, and prison healthcare is, a pretty contentious sort of area, and I think it just in general, and then also with stigma and the balance between sort of correctional justice priorities and healthcare, I think that's definitely something that, I would love to see that happen. I think that it's extremely necessary. So touch it out, Jacqueline.
Partnerships are just everything, aren't they? And you clearly had a really, really good partnership and lots of support from Peninsula Health in this project. Can you tell us a bit more about how you managed to foster that healthy partnership and get that support?
I think that came from the chief investigators initially. So they had, long before this project, been building those relationships, and then collaborating together with those services and having those investigators on the team as well. So every step of the way that they were there. And then and then especially with Kirsty Morgan then being able to be that point of contact and ascertain that there was that appetite within the service for the stigma education program, we were able to focus on that and strike while the iron was hot as such. And, enable that to continue. And now that's continued past out the project, on the other side of the project as well. So it was really that there was that appetite there. And then, then that information was be able to share back within the organisations. And then the decision makers there were able to come on board and see the value of it and run with that as well.
Mm. And we have a question from an anonymous attendee asking about your experiences of working with culturally and linguistically diverse communities and implications of stigmatising languages for that population.
Yes.
Did that come up at all?
Yep. No, well, I personally don't have that experience, but it is something that definitely needs to be considered in every research project as well. And especially like the stigmatising language, and then there is the use of language and the meaning of language within certain cultures and things like that as well. So it is very important, but unfortunately I can't speak to that, no.
Yeah, and there's definitely contact people that you can get in touch with. So if you were wanting to actually get that, either a much broader sort of base of people to respond and give as participants, but also, if you were wanting to specify, if you were really wanting to work in specifically with a cold community, then definitely I would say very early on in the process, if not right, before you start, get the relevant community involved as well, because they'll be able to help you guide your way through with, stigmatising language, culturally sensitive practice as well. So then, you can make sure that you're doing the best work with that community.
Yeah. Lil's asking, do you think with decriminalisation attitudes and language will organically evolve to being more respectful?
I think it will help. I think that it's going to be a process, even following decriminalisation, because for so long it's been seen as a moral issue, and it's criminalised at the moment. So I think it's very much a blame game, and people are seen as less than and they're stigmatised against. And I think trying to erase decades of that is going to take a long time. Hopefully eventually we get there, and that the moral aspects of things are changed.
Yeah.
I think a lot of the things that we experience as people who use drugs is, that those flow-on effects simply because it is illegal, and, getting held back in employment and things like that because you've got a criminal history. Over time, those things, I think, will hopefully change, but it's not going to be an automatic, and it's going to be a super slow progress, unfortunately, I think.
Yeah, and Lisa's asking if, with regards to some of the older participants that you had in your project, would you feel it? I don't know if you did have what the age range was, but did you feel it would have been helpful to have an older person with lived experience in that situation, so it's sort of age matched? Yeah,
definitely. Definitely. Our participants actually did speak at length about that, sort of not in respect to me, but just in general when they're accessing services, that they would love to see more lived experience peers of their own age group and similar experiences. I remember, one participant was saying when he was talking about his counsellor was that, yeah, she was a lovely kid. She was a kid, like she was 20, and he, was a lot older, and he really felt that it would have been a lot more beneficial being able to speak to someone, on that's had that similar experience and life experience. And I think that also goes with our, use of peer researchers as well. But, when we're looking at different cohorts of people, we need to, potentially look at who's actually doing the interviewing, and, that's something for future projects.
Yeah, it's a really important consideration. Ben, there's a question from Ben for you, Leanne. Did you find the interviews without Amelia were different in terms of how you could engage participants or build rapport with them?
I think rapport was still built, but I do believe that just being able to pick up on those little little gems within the interview, that where you can delve deeper, that having Amelia there is definitely, she would be able to pick up on that straight away. So yeah, I think that they were different in that context, that those sort of, that's that richer data, and being able to question further in real time. Like I say, it's in the real time. Yeah.
Yeah, I mean, ideally, every research interview we do going forward has the mix of, somebody with lived or living experience and researchers with the training in the methodologies, or some combination of that would be.
And I have to do, like, as we went along, because we did do a large number of interviews for qualitative, that, I did learn along the way, so I could make some other inquiry, or my ear sort of picked up a different thing. So I learning along
that mutual learning.
Yeah.
Fantastic. Okay, I think we probably should look to wrap it up. I just want to thank you both again for such a wonderful presentation, and there's been lots of comments saying just that in the chat. So thank you very much, Leanne and Amelia. I'm sure you'll be getting some inquiries for the posters and some further information. We've had people ask about where they can access the papers, and I've put your email address in there. I'm just going to do a quick plug for the next Connect and Learn webinar, which is on the 28th of March, 1 till 2, and that's Escape the Vape, supporting young people to quit vapes. And that's presented by Dr. Bronwyn Milne and Mary Wanhub. And then the next talking point is on the 19th of April, 1 till 2 p.m. And that's that's by Three Sides of the Coin, a performance which empowers people with lived experience of gambling harms to educate community and professionals. And that's presented by Judy Avasar, Catherine Simmons, Anna Bardsley, and Fiona Reid. So if you're around and available then, please join us again. If not, those talks will also be up on the Turning Point website, usually within a week or so of them being recorded. So thank you, everybody. Have a wonderful afternoon, and see you next time.